Hello, my name is Nick Hamilton. I'm a consultant neonatologist in Newcastle. I'm very sorry I can't be with you at the conference today, but I'd like to thank Alex for organising it and inviting me to present some of the work that I've been working on with her and many others. So in this brief presentation, I'm going to introduce you to a new online learning course that I've developed with Alex and many others, and also give you a brief update on the butterfly project, which some of you will probably know about already. So what we've created is a 4-hour course on managing uncertainty in perinatal medicine and palliative care. This is based on the BAPM framework that Alex led with many others. And what we've done is we've added various elements to that framework and worked with a number of parents and support organizations to create this online resource. And it's on a platform called FutureLearn, but you can access this via the NHS, and I'll show you how to do that. And importantly, I would like to acknowledge the support from many organizations in the UK and also some from overseas, so particularly SANS and BLIST and Child Bereavement UK, but also a number of other charities who've helped review the content for us and parents who also work with those organizations. And if you want to access this for free via the NHS, you need to go to the Learning Hub. And when you find the Learning Hub, you'll then be able to put in the search terms. So you can just search for the course by name, and it will take you through to applying for the course. And you'll see here in the bottom right the tick, because this is the course you're going to select, Managing Uncertainty in Perinatal Medicine. But you'll also see above it two of the other courses that we have, one of them on lactation after loss, and one of them dealing with the butterfly project, loss of a baby in a multiple pregnancy. And all those three courses you can do for free if you log in with an NHS email address. And if you know people who want to do the course, but they are not on NHS, they can still access it for free, but they need to go via FutureLearn direct. Just Google FutureLearn. And then if you scroll to the bottom of the page, you can do that course for free as well, but you don't get a certificate if you don't go through the NHS route. And in this course, we cover a number of different topics. We review some of the complex fetal and neonatal conditions that all of you will be familiar with. We emphasize the importance of listening to parents, the challenges of communication, both verbal and non-verbal, the importance of working as part of a multidisciplinary team. And we address some of the ethical challenges, the importance of parallel planning, memory making, end-of-life care, and many other topics in this 4-hour course. And the course has been open for a few weeks now. We've had almost, I think, 300 people join up already. And the course is broken down then into a series of weeks where each week is 1 hour of work. And we've had good engagement from nurses and doctors, allied health professionals, but also parents. And we create the course using kind of graphics as well as audio and video. And so over each of these weeks, we address various different topics. Now, as we start off, I just want to emphasize that we don't want to get ourselves trapped in specific terminology. All of you at the meeting today will understand what we mean by palliative care. But many other people get this confused with end-of-life care and confusing perhaps with supportive care. But of course, all of us working on neonatal units want to be focused on promoting survival for all of the babies we're caring for, but recognizing sadly that some of these babies are not going to survive. And so some of the babies that we're offering treatment for will end up going down an end-of-life care pathway, and we will be supporting parents post bereavement. But also many of these babies that have uncertain futures will survive, and therefore we need to be very cognizant of the need for holistic family support and parallel planning, but also all the various aspects of symptom management and loss and bereavement support. Now, terminology differs, different neonatal units, populations, and cultures use different terms, and so people's understanding differs. And to many people, as you'll know, if you start using the term palliative care, to some people, particularly parents, it might sound scary, like you're kind of giving up. But of course, we understand palliative care to also embrace active care. And what we're trying to do in this course is promote a philosophy and a way of practicing this rather than talking about specific terminology. But part of being honest as healthcare professionals requires us to parallel plan. Now, when I started out in neonates 30 years ago, this was the typical approach. Then the doctor can be along and speaking to parents, saying, look, trust me, I'm the doctor, we'll try our best. You do intensive care, and then you realize that actually things aren't working out, and then you think, oh, well, we should be doing some memory making, and we switch quickly to palliative care and end of life care. That was the traditional linear approach. But this, of course, as you know, is the parallel planning approach. We need to do this from the very first minute. In fact, parallel planning should start during the pregnancy. It requires us to be honest about the uncertainty that we as healthcare professionals don't actually know what's going to happen to any of the babies under our care. So whilst we practice intensive care, we need to also be thinking about how we practice palliative care, and we need to improve, emphasize the importance of FI care, memory making. And then all of these parallel approaches may end up in different situations: survival within follow-up, palliative care outside the hospital setting, end-of-life care, trauma support, and debriefing for babies that survive but parents have had a very difficult time. And in the course, we developed some case studies. So here's a case study focused on a pregnancy where the fetus has been diagnosed with trisomy 18. And we emphasize these 5 key elements of perinatal palliative care that Alex promoted in the BAPM framework. And these elements are the importance of support, empowering parents, planning with the whole team and parents, treating the baby, and then dealing with loss. And over the 4 weeks, we deal with lots of different aspects of it. I don't intend to go through each of these steps in detail, but you'll see that each week is made up of about 10 or 12 steps, and each step will take you 3 or 4 minutes to work through. And we cover some of the aspects of having conversations, continuity of care, the importance of compassionate leadership, culturally sensitive care, working with interpreters, legal and ethical aspects, and transition and planning. And we do that using graphics as well as text, but also include videos and audios with parents and discussions with your peer learners. And I think these conversations that develop are one of the unique aspects of using FutureLearn. It allows all of you, all of us as educators on the course, but everybody who takes the course, to provide their own opinions, insights, and knowledge to the different steps that appear in the course. And so these are really an important aspect, and I particularly enjoy logging in and reading about other people's experiences and also learning from them. Now, I don't want to go through each of these steps in detail, but I'll just kind of briefly show you some of the kind of things that we cover. So here's a step about the various aspects that require to have a complex antenatal conversation, checking in with the other health professionals, being clear about the diagnosis and the likely outcomes, being clear about the parents and the family that we're speaking with. And then it provides a bit of a schema for how you might work through parents' knowledge and uncertainties, helping make sure that they feel in control. The importance of us being empathic and acting with authenticity, but also aspects like cultural backgrounds and how we may present complex statistics. Here we talk through some of the things that you might want to think about before you go in, the importance of knowing the details, having an appropriate setting, checking parents' understanding, and working through all of this in the conversation you're going to have. As I said earlier, we want to emphasize that palliative care is an active approach. It is not synonymous with end-of-life care or bereavement care. And when we're thinking about parallel planning, we're thinking about the babies and the parents. We need to consider both the physical and emotional aspects that are going on, but also the social and spiritual dimensions to the care that we're providing. So when we start developing the conversations with parents, we want to acknowledge that some parents in the antenatal setting are going to have more challenges. They may have difficulties getting to clinic and accessing transport, or they may require childcare for other siblings, but also the importance of language translations. And then you can see on the right here the different aspects, the elements of effective communication, thinking about the setting, about your phones, about responding with empathy. Now, starting off these conversations is quite challenging. Here are 5 key questions that were included in the BAPM framework that Alex led. 5 key questions that might help you start conversations with parents. So these are: tell me about your baby, or tell me about your family. What have you been told? What do you already understand about your baby? What are your hopes for your baby, and what actually is most important for you and your family? What is it that you're worried about most? What do you fear about what might happen to your baby? And what do I need to know as a health professional to help you and your family for the best outcomes here? And then some people came up with this other approach, which is wish, worry, wonder, which I think is really quite an easy, nice way of thinking about it. So the questions that you might ask like this is, what is it that you wish for your baby? What is it that you're worried about? And then that leads you as a health professional to say, I wonder if it would help us to think through what would happen if Keith becomes more unwell again. Culturally sensitive palliative care is a massive topic, and we only touch on it briefly here. But we provide a series of things that you might say. We're not suggesting that you learn these and read these out, obviously, but things that might help get a conversation going, such as, is there anything related to your culture or religion that we should know about so that we can help you care for your baby? Do other people in your family share the same beliefs? So a series of openers that may help us address some of these cultural issues. This came from work from an American group. I think this is really important, actually, that all of us should consider our own biases and assumptions. What is it that we know about the population of families that we care for? Are you a person of color, or are you white European? And how does that impact on your practice and how parents and families may perceive the care that you're providing? And then on the right side, we can help you think about some of these other aspects, things that even someone who's been in the profession for many, many years might have overlooked when thinking about the care that we provide. We also provide some practical advice about working with interpreters, the importance of avoiding double negatives, the importance of avoiding compound words like can't. I never really thought about this in the past, but you see many people where English is not their first language, may not hear the word can't and may actually hear can instead. So really thinking about some of these aspects. And then the abide mnemonic on the right-hand side is a great way of thinking about how you work with an interpreter, arrange an interpreter, briefing the interpreter beforehand, conducting the interview, but then importantly, debriefing with the interpreter afterwards and providing an evaluation. We provide some examples of letters and advanced care plans with some phraseology that we have used ourselves. We emphasize the importance of continuity of care, so not just informational continuity and management continuity, but the importance of relationship continuity that we develop during the care we provide. We cover some aspects of end-of-life care and some of the challenges that all of you will be familiar with. The importance of getting the data. And then we have some audios with some parents. I want to thank all of the parents who were brave enough to help us create this course. I would encourage all of you to go and listen. So this is Danny, who had a baby who had hypoxic ischemic encephalopathy and sadly died after a few weeks. And I would encourage all of you to go and listen to what she has to say and the other parents in the course. Now I'm going to quickly move on to some updates about the Butterfly project. Again, many of you will be aware of this project already. So we have a website And then we've also developed an online learning course. And this developed out of qualitative work that we conducted with parents and staff. It focuses on multiple pregnancies where one of the babies died either as a miscarriage, stillbirth, or neonatal death. And working with parents, we've produced guidelines and films, and then we've produced this 4-hour course. And this very much encourages you to, I think, to think about things from the family perspective and realize that we're dealing with all of these aspects every day in our work environments. And these life stories are very important to parents as they come to terms with the challenges that they've faced. And overall, parents were generally very positive about staff. They said it was a bit like these little things, humanity in a technical world. But importantly, what I've learned from keeping in contact with parents many decades later is that they remember exactly how he made them feel in these challenging times. And this unique bond that they form with many of us. And what I also learned was that they don't expect us working in neonatology or maternity to necessarily be counselors or miracle workers or priests, but they do expect that we genuinely care. And our project focused on this situation where you have twin or triplet pregnancy, where one of the babies dies, but at least one of the babies survived. And I think many of us are fascinated by twins. Twinning rates, as you know, are increasing worldwide due to a whole series of factors. But many of us are unaware that there is such a thing as a twinless twin. I mean, none of you would know if I'd had a twin who died at birth. And Elvis Presley was a twin. His brother died stillborn half an hour before him, and it's said that this dominated his life. So losing a baby from multiple pregnancy, as I say, may happen in lots of different situations. It may happen following a pregnancy due to assisted reproductive techniques. It may happen on the neonatal unit. And we were interested in how parents coped and how we as staff can either help or hinder the bereavement process. And here are 6 kind of scenarios that I think all of you will have had to think about. You know, what does it feel like to be the sonographer when you only hear one heartbeat? What does it feel like to be the nurse that comes on duty and cares for a baby and nobody told you that they had a twin who died? And what does it feel like to be the parent when you get to go home and you worry about how you're going to tell this baby or child that they had a brother or sister? And in our studies, we came up with these 8 themes. I'm not going to go through them in great detail because you can learn these in the course. But all of these things are about acknowledgement, acknowledging the identity, acknowledging the bereavement, and acknowledging how challenging this can be for parents. And it was in our workshops with parents that parents suggested that we develop the butterfly symbol that we've now been using for about 10 years. And this is spread across many hospitals in the UK and wider. And as you know, it's a very simple thing. We encourage parents to write the name. Of course, here are 2 twins on the unit who didn't know until we started using the butterfly cock cards that they were survivors from a multiple pregnancy. And these parents got to know each other and are still in contact with each other several years later. And one of the things that parents told us was that everybody said to them, at least you've still got one. And I think a lot of people found that, not surprisingly, incredibly challenging. So one of the things we want to do is encourage people to think carefully about the words and the language that they're using. And we developed a series of guidelines that have been translated into about 15 different languages. We worked with Millie from Sky High Foundation. And then we developed also an online training course that you can take. And this butterfly symbol became very powerful. Parents had tattoos. They go and visit butterfly farms. The surviving siblings will take a butterfly on their school bags. And the feedback from the course has been amazing. I think the 2 versions we've had so far have had about 3,000 people do it from more than 90 different countries around the world. And then last year, we contacted the families again to find out more about what family life was like. And we had over 200 families collaborate with us, and we've been making some films. And we really wanted to know, what is it that parents say when they're asked, how many children do you have? And what do they do on the birthdays or anniversaries of the death of the babies who died? And I'm just going to go through a few of these quotes. I'm a lone twin. My identical twin died at 5 days of old age, and I've always felt that there was some part of my life missing. Being a lone twin affected me growing up. I've never felt like I fitted in anywhere. I've always had a feeling of loneliness which I can't explain. My survivor has always known she's a twin, and we've talked about this in different ways as she and her older brother grew up. However, I've still been unable to tell them that I had a termination for medical reasons for Susan, just that their sister died in the womb. Now they're grown up, I wish I'd told them before because now it feels like a huge deal. How many children do you have? Well, if it's someone I'm going to have a long conversation with or someone I will see again, then I say that I have two children, but that Kai is a twin and that his brother died at age 12 hours of age from a heart defect. But if it's only a fleeting conversation with a stranger, I don't mention it, but then I do feel guilty afterwards. I feel as though no one mentions it or asks, so I feel awkward bringing it up. I just sometimes want it to be acknowledged. I feel no one else remembers my lost baby or how sad it is that she's not here alongside my survivor. It feels like an exciting club that I never quite got access to. Many others still consider themselves a twin mum, even though they lost one twin, but I don't. I never got the opportunity to feel like a twin mum, and it seems such a special thing that I missed out on. It makes me feel sad for Kai that he will never know that bond. From as long as I could remember, I had a friend who I could speak to, touch, and see wherever I went. Around the age of 8, I told my mum and said it was more than an imaginary friend because he was part of me, and without him, I didn't feel whole. My mum then told me that I was a twin, but that he didn't survive the pregnancy. Here's another parent. My mum told my older sister and me when I was 7. She'd been describing my sister as a beautiful baby, and I asked if I was a beautiful baby too. She said, "No, you were horrible, all red and small," and revealed that I was a premature twin. She said that my twin died because I took all the strength, and I felt her disgust. So we cover some of these aspects in the course, but obviously the follow-up information from our recent studies isn't there yet, but we will be making a whole series of films. So I want to emphasize that this is about our behaviors and actions, not about using a butterfly card. And really never underestimate the power you have to make a positive impact on these families' life. Act as a leader and demonstrate that this is important to others on your unit. And as I say, that's just wrapping up here. So here again are the links. Anybody can search for these courses on FutureLearn, but you can also get them on the Learning Hub if you're NHS. And those 3 courses are all available there. You can all join and certificate for free. And I'm going to finish there and hope I didn't overrun too much. So again, thank you very much for the invitation and sorry that I couldn't be here today.